We are continuing our theme of saving lives. We've seen the power of saving lives one at a time with Dr. Talreja. Now we turn to our speaker, who's been responsible for policies and procedures that have likely saved thousands of lives in combating the scourge of two major diseases, HIV/AIDS and COVID-19. Currently, she has turned her arsenal on the problems of rural health and how to improve access and quality of care. This has now become even more important for all of us, as from my vantage point, the line between rural areas and urban areas is getting thinner and thinner in terms of shortages of access to care, medicines, and supplies, which are having trouble in urban areas as well as rural areas. Our speaker, Dr. Deborah Birx, is a physician and global health specialist whose career spans more than 3 decades of service in some of the world's most challenging health environments. For those scoring at home, Dr. Birx is boarded in internal medicine, allergy and immunology, and diagnostic and clinical laboratory immunology. Somewhere, Dr. Krueger is smiling over another boarded physician. As former U.S. Global AIDS Coordinator, she led PEPFAR's, which is the U.S. President's Emergency Plan for AIDS Relief, expansion to reach underserved populations across 50 countries. During the COVID-19 pandemic, she served as White House Coronavirus Response Coordinator, where she worked tirelessly to bridge gaps between science, policy, and community action, swimming upstream most of the time. Her leadership has always been guided by the belief that innovation and partnership, when armed with appropriate data, can overcome even the toughest obstacles. In fact, word has it that the D in her name stands for data, not Deborah. Dr. Birx has a deep understanding of how geography, infrastructure, and workforce issues shape health outcomes in rural America. She has collaborated closely with clinicians and community leaders from the Great Plains to the Appalachian foothills, witnessing firsthand the power of telehealth networks, community health workers, and locally driven prevention programs. She has personally driven to many of the states to get their perspective on how to solve problems, speaking from the governors down to local health programs, and even going on college campuses to find helpful ideas, if such a thing is possible, and try to spread her view of data and how to improve health care, first from individual disease and now general medical care. Today, she'll share both the data and the stories that illustrate what's working and what still demands our attention to build a stronger, more resilient rural health system. And the hope is that these same methods will also work in urban areas such as ours. Please join me in giving a warm welcome to Dr. Deborah Birx.
Younger, that's awesome. It was 4 decades, but good. Really, congratulations. Really, it's such heartwarming to see your acknowledgement of your family and the community, because in the end, that's really our legacy. And I just really appreciate being here to talk about this award, the individual who really started this award. So I was trying to understand John Krueger from what's on the website. It could be more on the website and more details about his life. But I loved it when it says that he was revered by patients and physicians alike. Now, having trained and worked all over the world, that's a very odd comment for someone that's a pathologist. And it just shows you how much of an incredible human being he had to be. Because I have to say, I never asked a pathologist for advice on how to take care of my family. But you all did. And I think that really shows how much he was bigger than his subspecialty. And I think that's what I heard tonight, is how much bigger you are than your specialties and your subspecialties. And that's what really, I think, defines us. I was trying to think about what to talk about, and then I saw the website, and I changed the talk yesterday to really, it's really not a great after dinner talk, because part of it is about us and how we carry perceptions. And when we look at data and science, we interpret that data and science based on our personal perceptions at times. And unfortunately, what's happening now, it's almost based on what party you belong to. And we look at scientific evidence based on whether we voted blue or red, right or left. And I hear it now in the media when physicians are interviewed. And I'm worried that we have never gone that way. We have never given speeches or talks in the media about and picked a position, not based on the science or the data, but our personal interpretation of it. And I think if anything is going to destroy public health, it's going to be that, because the community can sense that in us. They can sense when we're taking a political position rather than a science and data position. I've worked on a lot of pandemics. It's why in the end I came back from Africa to work in the White House in 2020. I said no many times. But I was an active duty Army officer for 29 years, and they had a Marine call me who was and said, you know, this is your mission, this is your duty, get back here and do it. And I was like, oh, yeah, okay, I'll do it. But all pandemics are political. It doesn't matter where I am in the world, Zika, Ebola, HIV, TB, very, very political. And why is it political? Because first, no one wants to admit that that infectious disease is in their country. And so all countries have a habit of hiding an infectious disease, which puts us all at risk. I remember working with the Caribbean during Zika, and they were like, well, we don't want to say, because no one will come then to the Caribbean for tourism, and tourism is our key value. And so physicians even got pulled into that, and that's what we have to be careful about, because we can't ever prioritize the short-term gain of financing over the long-term gain of people's lives. And so all of these epidemics have had misinformation. It was so funny to me when people were like horrified about the COVID misinformation, and I'm like, did you forget HIV and mosquitoes and going to Central America for alternative therapies? I mean, do we remember that? It was just 40 years ago. I was just out of medical school practicing, but we forgot that. And we were like horrified that there was misinformation. There's misinformation because when people are really sick and afraid, they'll try anything. And hope is critical. So if someone gives them hope and says, you can try this and it will help, they're gonna do it. I mean, people ask me all the time how ivermectin came to the forefront, and I was like, have you been to rural America? They don't have a John Krueger, but they have really good vets. And they're getting their medical information from their veterinarian because there aren't physicians there. So this is what's happened in a lot of rural areas. So it's not, to me, it was not unusual that someone came forward with ivermectin because he saw some of the patients and it saw the people in the community do better, and then it spread by wildfire. So I've always really believed that you have to get to know the communities, because otherwise your message is lost. And it was really encouraging for me to hear how you all work together at the community level. I got to see that during COVID. It was really magnificent to see. But that's how you can also lose a community. I remember when they first started rolling out vaccines and they kept saying, go to CVS and Walgreens. Well, I had driven this country. There are no CVS and Walgreens in about 50% of the country. So when you say that, you've lost that community. Because that community then says, those people in Washington don't know me and don't understand me. because my closest vaccine place is 2.5 hours away. And so when we started criticizing the rural America uptake of vaccines, a lot of it had to do with access and our inability to really figure out how to deliver vaccines at the most local level. Some of you became so creative during COVID with monoclonal antibody infusions, and there were governors giving that in libraries. And yet, when it came to vaccines, a lot of us didn't use the school systems and there's a school in every district. That's why they're called school districts. So they're there, and they're in rural America, and that would have made a big change. But I wanted to talk also about how important political will is, because it's political will that allows that individual that you're speaking to take the data that you're presenting to them and change that and put that into policy that changes lives. And it's the data that allows us to speak to people. I really think it's the music that unites us. So I would rather be on my computer looking at data than listening to music. I know that's like so crazy. But data to me speaks to me. It creates pictures in my head. But data is what allows you to go to leadership and say, this is the wrong assumption. This is the wrong perception, and here's why. And it's political will that allowed us to work all over the globe to get presidents and prime ministers to deal with the epidemic that they had, not the epidemic that they wanted to have. Everybody in sub-Saharan Africa wanted to have a mommy-baby epidemic. It looked nicer, it seemed nicer. When it started to be clear to us that it was really an epidemic of 17 to 25-year-olds, no one wanted to talk about it anymore because the Minister of Health said, I have a daughter that's 17, she is no way having sex. And I said, well, wait till she's 25, because then they'll come back and tell you. I raised 2 daughters, I know this now. I'm sorry, you need to work on that. They don't tell us the truth when they're younger, but that was happening all over Africa. And so getting presidents and prime ministers to deal with the fact that they had an LGBT community, that there would be men having sex with men, that there would be young girls having sex with 35-year-olds. These are realities that were driving the pandemic, but no one wanted to talk about. I made this slide 8 years ago, in 2017. I made it to talk about political will. Because the Ukraine, and it's just amazing to me that this war continues today, but there was a moment, and still is today, Russia stopped giving their data to UNAIDS, so I have no idea how bad their pandemic is any longer. Both of them had a pandemic, primarily their HIV was in people who inject drugs. Ukraine realized about 10 or 15 years ago that people who inject drugs are not going to come to their public hospitals and get care. So what they did is they created peer, local NGOs that did all the outreach, that got people onto medical assisted treatment for their drug addiction and got them onto effective HIV drugs, all done outside of the public sector, and they paid, the public money went to this NGOs. Russia refused to do that. And you can see, even to this day, I am sure, their pandemic continues to rise with now over millions of people infected. And Ukraine's is getting better. And Ukraine's is getting better and continues today despite the war. Because when you work at the community level, they figure out how to get it done no matter what the odds are. Sometimes we can't figure out how to get it done, but they will. And if we listen to them, they'll tell you how to reach people. Within HIV, we thought we were doing great. We were applauding ourselves. We had millions of people on treatment. And we decided that we needed the numerator and the denominator. And I challenge all of you to really understand what the denominator is in your community. What do I mean by that? Who really needs care versus who's in care? So we knew who was getting treatment, but we asked ourselves, is everyone in need of treatment getting treatment? And so we did a community-based survey. We've now done over 30 of them. They're called the FIAs. ICAP and Columbia did them. You can go online and see them. And it was very clear to us that the epidemic was not a mommy-baby epidemic in 2014, but really an expanding epidemic in young men and women. And this was at a time when we thought we were doing so great. All those hatched lines are HIV-positive individuals who had not been diagnosed and were not on treatment. And all of a sudden you realize for all the things that you thought you were doing great, you're failing. And I think that's so hard for us to admit to ourselves that we're failing, that there's a group that we're failing, and how do we figure it out? So if you look at this slide, women were on treatment. Why? Because we're forced into the healthcare delivery system through pregnancy. And that's the same no matter where you are in the world. And so mommies want to protect their babies. They were going in, they were getting diagnosed, they were on treatment, they were staying on treatment. But young women who had not yet been pregnant had no access to testing or any interest in getting testing, because remember, they're asymptomatic. And young men in the same way. And children we were missing because they looked okay. Now this has always been my message to people. You can look great and feel great and have something that's a big problem. And so we really worked with these communities to get them on treatment. Men were particularly difficult. I did a lot of focus groups with men. And finally, after years of beating my head against the wall, I called in Johnson & Johnson and said, I need help. Always ask for help. People will help you. I called them up and I said, I can't reach men. Could you hold focus groups because you know how to sell things and you get people to buy Air Jordans and he hasn't played in 40 years. So Nike and Johnson & Johnson helped me out. They came in, they talked to the men, and they came back to me and they said, they like that you got the male nurses, they like that you're open early in the morning, they like all these things, but they only listen to one person in their lives. Now, as I mentioned before, I raised 2 daughters. Men will only listen to one person, their mothers. What did we do? We knew where the mothers were. The mothers were in church. We went to church all over Africa, every community, gave them self-tests, say, take these home, take this self-test to HIV home, get your son tested, and if they're positive, get him on treatment. He can live a normal, productive, thriving life, and you will have saved his life. Moms can really get their sons to do what they want. We got 2 million men on treatment within 18 months. So finding the power of moms or the influencer is really critical. And so we used all of our failures to really constantly improve our program. And this is Eswatini. When I started in PEPFAR in 2003, when it was announced by President Bush, 50% of the adults in Eswatini were HIV positive. And with this program and your taxpayer dollars, we have dropped deaths by 85% to 90%, and we have dropped new infections by 75%. And this was possible without a vaccine. So when people tell you something is not possible, everything is possible if you find out how to work at the local level and really work with the communities and hear what they need versus what I think they need. And that made all the difference. And you can see for the first time in Africa, we have better numbers than the United States. We have 95% of people that have HIV diagnosed, on treatment, and virally suppressed. For the first time, we're seeing that the population of HIV positive people in Africa is declining. And it's declining because they're aging into the age of natural actuarial tables. They're getting into their 60s and 70s and dying from non-HIV causes, which is really quite extraordinary when you think about 50% of this population was HIV positive. Coming back to perceptions, I'm going to cover 2 more diseases that I really think we all have to learn from. Of course, one was COVID. And the reason I wrote the book, and the reason people think I wrote a book for a very different reason, but the reason I wrote that book is because our agencies, our federal agencies, were focused on an epidemic that they wanted to have. They wanted this to be a flu pandemic. They had prepared for a flu pandemic. All of the red threats that we had done on tabletop exercises was a flu pandemic. So they were trying to push COVID to look like flu. And if you remember early on, all we did was screen for people with symptoms. Well, we let probably 90% of the people who were infected back in the country, sitting at the airport saying, do you have these symptoms? Well, now we know 50% of the people who are infected don't have symptoms. So you cannot make a disease into something you know just because it's convenient. And because of that, our federal agency, the CDC, did not make tests outside of their public health tests because they were going to track this by symptoms. You have to make invisible asymptomatic viruses visible. You have to make them visible through testing. You have to find the people who are asymptomatic because you know what? People who are sick don't go to parties. So if you're sick and you have a fever to 102, you're not going to probably be out going to a party unless you're under 21. This was the data we had. So I just want you to think about this. This is 2 months into COVID in the United States. This is the beginning of March, and this is our database. It shows 1 case in New York. This is the first week of March. The first week of March. So when you try to see a virus through symptoms, you've lost the battle. And this is what happened. So I called in all my friends, because I've worked only globally, so I called them all up, all these ministers of health all over the world, and said, what are you seeing? Because I don't have any data, and I don't even know what to say to the American people. So South Korea and Italy every night sent me their data. Now, South Korea was testing. Now, if you look at this graphic, they're finding so the young people are at the bottom. All the cases are in young people. All the deaths are in people over 75. Now, what does that tell you? That tells you that there's a lot of asymptomatic disease, okay? Because it doesn't just infect 80-year-olds or 70-year-olds. It infects everybody in the community. Because they were testing, all the cases were in the young people, all the deaths were in the old people. That gives you a message. Now, Italy didn't have, and this is their case fatality rates. And because they had the best testing, they really provided me great information. There was no real case fatality rate under 30. It was 0.1 or less, and it was 0. They had lots of cases, no deaths. Italy didn't have tests, so all their cases and all their deaths were skewed to people who were older, because the only way they were finding them is in the emergency room. They weren't testing in the communities. And so, but even looking at this, you could see very quickly that the case fatality rate was really limited to people over 70 or people with significant comorbidities. And it was based on this data that allowed us to be able to go out in March and say to the American people, this is who's at risk, and this is who has to be protected. And we're going to get tests. And it's going to take us a little while because we've called in all of our private sectors, and they're going to do it. We did have that 15-day and 30 days to slow the spread, and then we had reopening guidelines. I think the most important thing we did was we were able to get all of you to contribute data in real time. And I just want to call out the hospitals. People told me the hospitals would not give me data. We have 6,000 of them in the United States. By Friday, that same week that I asked for the data, I had 93% of the hospitals reporting. They're presumptive cases, they're ICU cases, they're confirmed cases. And why? Because we needed to get you PPE and remdesivir. And you did that for us. You got us that data. And then we were able to create very sophisticated trend maps so we could tell how long your hospital was going to get hit for and how much PPE you were going to need. And so we could rearrange the entire PPE delivery system. Cardinal, McKesson, all delivered based on where we told them that the PPE needed to go. And that's why you didn't see that many stockouts after July. And so data creates the opportunity to really create equity in the system. Because what we were seeing is the coast that wasn't getting hit was ordering all the PPE because they weren't busy. And the coast or the south that was getting hit couldn't get the PPE because they were too busy taking care of patients. And so we had to reroute the whole system. And in the end, we had these great maps that showed every county in the United States and showed every governor. They got this list weekly. Every governor knew precisely where he was in that trend, whether the cases were going up or whether the traces were going down. And I think we had incredible positive lessons learned. But a lot of those, you know, we are very short memory. Most of these things we have stopped. We've stopped most of the data streams. Operation Warp Speed was terrific, and we could have used that for other diseases of how to really work in a public-private partnership. Onshoring. You had supplies because we were going to the manufacturers and taking it off the assembly line. That's how bad things got, but we didn't make anything here. So if China decided to stop providing us with API and medicine, if you're on any kind of drug, you're not going to do well. We have got to get our pharmaceuticals back and back in this country. Now, COVID data. I'm sure you're not using your wastewater data. We're just finishing a great big surge. You're all looking pretty healthy. I'll show you Virginia in a second. But I wanted to show you flu versus COVID. Because again, this is what gets us into these wrong perceptions. When we tell people that COVID is a winter respiratory disease and to get your vaccine when you get flu vaccine, it is wrong. It is wrong. We have 2 surges per year. Flu's on the bottom, Virginia's data's on the top. That's your COVID wastewater data, your flu wastewater data. I'm sure you can all see that there's half as many peaks in flu because there's a summer peak. So I'm worried. I mean, a lot of our elderly have not been immunized because we told them to get it in October. By October, the peak is over. And the surge is not going to be now until February or March. Their vaccine will have waned by then. So if we're going to collect data like wastewater, we really should use it. Because we're immunizing the elderly on a completely incorrect schedule. When you see your wastewater go up in Virginia, that's when you go to the nursing homes and say, it's time to immunize. And then they'll be protected because the immunization, natural infection immunity wanes over 4 to 6 months. I won't go into all the immunology because it's dinner. It could take for an hour or two, but it wanes because we don't make full memory response to COVID. We're not going to. We can't do better than natural infection. It's not going to happen. So if you have people in their 70s and 80s and they're at high risk, they really need to be immunized every 6 months. But it needs to be based on what's happening with COVID. So they should have been immunized in August to protect them against this surge, this late summer surge, which we've seen now 2 years in a row. And they need to be re-immunized again in February to protect them from the spring, which would be the late winter surge, because again, it's going to be 4 to 6 months in between the peaks. So it's like a math problem. The peaks are pretty regular. We've been through this now for 5 years. We need to use the data. Let's not make a disease into something because it's convenient for us. People can understand nuances. If you tell the people over 75 that they need 2 shots a year, they'll get 2 shots a year. But don't tell them to get their shot with flu, because it's too late now. And by the time COVID comes around again, they're not going to be protected. So these are what you can do. Measles. Now, I'm sure, a raise of hand, how many people think the Texas outbreak was due to vaccine hesitancy? Come on, be brave. I know it's a trick question. It wasn't. It wasn't. In fact, it was an illustration of the great work that parents have done in Texas to immunize their children. Now, you wouldn't know that from listening to the media. The outbreak in Texas was in Gaines County. This is a classic outbreak of any infectious disease that goes through an entire community because the Mennonites were never immunized. It's just like the Hasidic Jews of 2019 when they had their outbreak. Mennonites, Amish, Hasidic Jews have never gotten childhood immunizations. This is what the profile looks like when you have an unvaccinated population. And if you look at the CDC data, the big red flag to the fact that this is an unvaccinated community was a third of the cases were in people over 25. A third of the cases were in adults. So, but what this other part of the slide, geez Louises, you can't see. Okay, well, I can make up any number now. You guys over there can see it. The attack rate in Gaines County ended up about 2 to 3 per 100. The attack rate in every surrounding county was 1,000 times to 100 times less. Why? Because their MMR immunization rates were above 95%. And so what was a real opportunity to inform the American public how herd immunity works and how much it protected the people in the surrounding counties, it was a story of positivity. It was a story of hope. It was a story of what you do every day. It was telling parents, great job. But that's not what you heard. They made it into vaccine hesitancy when we could have said to the American people, this is what herd immunity looks like, and thank you for immunizing your children. Because you protected every surrounding county, including Lee County, which is on the New Mexico side of Gaines County, because it's right up against the Texas-New Mexico border. It was a story of great public health. But we turned it into a finger-wagging thing. On top of that, we did not offer that Mennonite community testing. We offered them vaccines. Now, this was a community that was not going to get vaccinated. So if you give people the tools that they're never going to use, it's not good public health. It may make you feel good because you're saying, I put a vaccine ban out there, but what they needed and what they would have done is they would have gotten their children tested before they gathered, because they're very protective of their community. So if you had offered them rapid measles testing, which we have, there were a few sites. They didn't make it available at the communities that really needed it. They would have not spread measles. Now finally, I'm just gonna close with something that has become my dear passion, because we figured out how people in Africa, no matter how far of the end of the road they were, we got them their drugs, and we got them HIV, we got them tests, and we got them viral load, and it didn't matter where they lived. And we had great data. But I think what COVID really laid bare is how bad our underlying health is. And unless we start moving to finding asymptomatic disease in people who think they're well, you all are doing a great job, and you're saving lives. But we could prevent this from actually progressing. This is our diagnosis of diabetes. I mean, it's accelerating, it is not declining. This is obesity. When people say, how did we do with COVID? We actually did remarkably well for as sick as Americans are. That top line, that's us. I don't know if you can see Italy. Italy, they eat well. Obesity rates under 20%, Japan 5%. Our obesity rates are not only high, but every other developed country has figured out how to level this out, and ours isn't. And our fatality rate from COVID was less than anyone in Europe, by and large. Less than Spain, less than France, less than UK, and that's you. You did that. You saved those lives. Because we are a lot less healthy than any of those other countries that got hit by COVID. So it is a testament to the medical care that you all provided, because our death rate should have been close to the UK's, which would have been almost twice as many people dead. So this is life expectancy. I show this slide not because it says that we lost so much life years under COVID, but we've been measuring this forever. And the tribal nations are dying at about 10 years younger age than us. And we're not doing anything about it. We just watch these numbers because we have this perception that nothing can be done. When I went to the tribal nations and I visited with many chairmen of tribes, because it was really important for me to understand what was going on, and they were very polite to me. And finally, one chairman stood up and said, "You come to us worried about COVID, but we've been dying of diseases of despair for decades, and no one has done anything." That was really hard to hear, because I had spent 30 years ensuring that no one died from HIV, TB, and malaria in Africa. And I have people in my country telling me that we've been letting them die. And we've done nothing to change this in the last 5 years. I'm going to end very soon, so go right to the dessert. This was published in 2019 in Scientific American, and this is where I can tell you we got politically off the rails before COVID hit. When you start calling counties Republican counties because they're rural, and Democratic counties because they're urban, and then it should have been labeled urban rural. I mean, why would anyone lay something about health care as a Democrat or Republican? I mean, I will tell you, there are Republicans that live in cities, and there are Democrats that farm. It's not this mutually exclusive situation. But this was published before COVID, and we've just been tracking that everybody has done better except every rural county. And it's for all of our advances in medicine, there's been no improvement in fatalities or morbidity or mortality since 2007. What really got me worked up was the fact that this is higher death rates among 25 to 44-year-olds. Age and sex normalized. Every place you see red says it's going up. So there's a lot of blue on there, California, and there's a lot of red in the south and in the rural areas. Now this was put out by the CDC a year and about 2003, 2 years ago. I would have been embarrassed. This is cancer fatalities. Those two circles up there, those are rural areas. Small metropolitans, you're probably in that large fringe metropolitan. Look at if you're in an urban area, look at how this is to me, this is preventable. I mean, see how it's labeled? You probably can't see it. It says preventable premature deaths. And we put this out and we just I want to know, what are you doing about that? So I know you act like this. I can see by how you work together that if you see something, you need to not just say something, but you need to do something. We all need to be part of this solution. So what we did is we went into the field. Everybody gave me ideas about what was wrong in rural America. I went out into the field. We went into a rural community. We went household by household. Hadn't been done in the US forever, but we had done it in Africa and it worked. And we found that 60% of the household between over 18 had underlying disease. Whether it was obesity, whether it was hypertension, or whether it was diabetes. There were more diabetics than there were obesity. 58% of the population in this small town of West Texas had a hemoglobin A1C above 5.7. 90% of them had never been diagnosed, didn't know they had it, couldn't believe the number of people who were diabetic. We found 22.5% of the town diabetic. CDC estimated it to be 7.9. So if we don't take the time to get the right data, we can't provide the right solutions. And there are towns and counties out there who have no idea. But we could have an impact if we could do something before there's organ damage. And so finding the 18-year-old, the 30-year-old, the ones who feel incredibly healthy but need care. And so that's what we did. And so I just want to end by saying, when we see these situations, when you see CDC put out a data piece like that, that shows that people are dying at a 20 to 35% higher rate in rural areas, we need to say, as physicians and care providers, this isn't acceptable. We need to really come together and I'm just going to conclude I talked to the local physicians. What they told me, because I got a little bit worked up, I do have that as an issue. I found a lot of diabetics that had hemoglobin A1Cs of 11 to 12 who were under care. And I mean, I'm going to emphasize under cared for. They were under care, and I went to the physicians and I said, what is going on? And they were like, well, you know, I don't think they can understand how to use insulin. So I'm just keeping them on metformin. Really? I mean, did you try? I mean, we can't make these assumptions about people. They acted like, so we're out there with solutions now. We're going household by households. We're giving continuous glucose monitoring. It's all available over the county now, so we didn't have to have physicians. They have their hemoglobin A1Cs, they have a Bluetooth blood pressure cuff, they have this really sophisticated scale that gives them their muscle mass. So women, those of us who are a little bit on the other side of things, of postmenopausal, we need to work on our muscle mass. It gives them bone mass, muscle mass. We give them this, they're gonna change their lives. And they're gonna change it without us, but we could be part of that. So I really let's not wait till people have the heart attack. Let's not wait till they have the stroke. Let's not believe that people in rural areas can't understand nuance and complicated medicine, because they can. If I can do this in sub-Saharan Africa, we can do it in America. And you can all be part of that solution. I know that when I heard what was presented today, when I read the website, I can see the level of dedication. And I think getting information and tools into people's hands so they can start seeing the relationship between food and their glucose and their hemoglobin A1C, it's going to be transformative. So thank you. I finished so you could ask questions, but eat dessert at the same time. Questions are good. Just stand up and scream it out.